We'll next go on to the presentation by Dr. Ankur Sinha, who unfortunately could not be here with us, but he sent his recorded presentation. Can we play the presentation by Dr. Ankur, please?
Good afternoon to each and everyone. At the outset, I would like to thank Dr. Digvijay and AIO's office bearers for giving me this opportunity. I'll be talking on basic neuro-ophthalmic examination. Now, neuro-ophthalmic clinical evaluation starts with history taking, ocular examination, which includes the visual acuity, consultation, pupil, and the fundus examination, systemic examination, and investigations which could be ocular or systemic. Now, vision loss is a very important symptom of neuro-ophthalmic disorders. The way it occurs, it can point towards the causes. So, if it is occurring within seconds and minutes, probably we are looking at a vascular or a traumatic cause. If it is occurring within minutes, hours, and days, then we are looking at an inflammatory or a cause because of elevated intraocular pressure. If it is occurring very slowly over a period of hours, days, and weeks, then we have a disease which is either a space-occupying lesion or a chronic or a degenerative disorder. Now, history taking starts with a duration, that is whether it is a recent onset or long-standing, whether the symptoms are improving or worsening, are there any associated complaints of headache, vomiting, seizures, history of any focal neurological symptoms or comorbid illness, family history of hereditary neuropathies or autoimmune conditions, treatment history of medications, and previous investigations. Now, visual acuity is a very important baseline parameter. Even if the patient has lost his vision at the time of presentation, but we can still ask that how the vision loss has occurred and when it has occurred. Snellen's acuity is more than adequate, but we should allow the patient to respond because sometimes the neuro-ophthalmic patients may take more time to respond than normal patients. Check for the best corrected visual acuity with pinhole. Also check the near visual acuity because in some cases, the near visual acuity is knocked off. Now, confrontation vision fields can be done at the bedside and they are helpful in detecting pituitary tumors, ischemic neuropathies, and papillodemas. This is also a good test to make the patient realize that what he is missing and what are the potential dangers of the neuro-ophthalmic disorders we are thinking of. Now, this is a photograph which is showing you how the confrontation visual field is to be done. Now, pupil are a very important part of examination. So, assess the pupil size, test the pupillary reactions, check for the near response, pupillary dilatation, and test for the RAPD. Now, measurement of pupil can be done with the help of pupillary gazes or handheld pupillary cameras. We also have infrared pupillometers where we can kind of document the pupil size very accurately. Also assess the pupil size in darkness, light, and near. A difference of more than 0.4 millimeters can be termed as anisocoria. Now, always check the reaction to light. For this, we have to dim the surroundings. Ask the patient to look at distance. There should not be an attempt to look for near as it can cause meiosis. And note the pupillary escape, that is once it dilates after constriction. Also note the latency of speed of constriction and dilatation, and also check the consensual light reflex in the other eye. Check for the near response, that is the near triad of meiosis, convergence, and accommodation. Use the dim light and use an accommodative target for same. Check the pupillary dilatation. Also check the reflex dilatation to sudden noise or painful stimulus. Dilatation lag can be seen with dilatation lag with anisocoria can be seen in patients of Horner syndrome, and it can sometimes be normal. Check for light near dissociation where light reaction is almost always impaired. RAPD can be checked with either a Marcus gun or a gun phenomenon or a swinging flashlight test. We can also use neutral density filters to quantify the RAPD as these density filters aggravates the mild RAPD. If both the pupils are not reacting properly, then we can check for the H light pupil cycle test. Here, a small horizontal beam of light is shown to the pupil. So as the pupil constricts, the light is cut off, the pupil dilates again. And we kind of count the number of constrictions and dilatations in 1 minute. And then we divide it by 60 to find out the time required for one pupil cycle. So if it is more than 954 milliseconds, it is not normal. Physiologic test can be done with diluted pilocarpine to check for supersensitivity, normal pilocarpine for pharmacological blockade, cocaine or apaclonidine for sympathetic defect, and hydroxyamphetamine or phenylephrine for postganglionic sympathetic defects. Now, this is the case of 12-year-old boy with drooping of lid for last 2 years. We can see there's a right mild ptosis, and right pupil is smaller than the left. So the patient is diagnosed as AD's pupil, subjected to a MRI where we can see there's a large paraspinal mass in the apical region close to the trachea. So patient undergoes CTVS surgery, and histopath shows benign nerve sheath schwannoma with cystic changes. This is another case, a 48-year-old male, where we can see the left eye pupil is larger as compared to right eye in the presentation. And when we do the direct light test, we can see that the right eye pupil constricts, but the left eye pupil doesn't constrict so well. So we can think probably that the left eye is not, left pupil is not working properly and the left pupil is abnormal. We also check the consensual right reflex. So right eye, when we shine, is constricting well when we shine the bright light on the left side. Similarly, when we shine the bright light to the right eye, the left eye doesn't constrict. So probably there is an efferent defect in the left eye. Also, when we check on the slit lamp, the right eye has a concentric constriction, but the left eye has vermiform-like constrictions. So, as we can see now, and this is at presentation, and this is after 5 minutes of reading. So, a sustained Neo work did cause some amount of pupillary constriction in the left eye. So, he's diagnosed as AD's pupil, and is prescribed asymmetric AD and photochromatic glass. Systemic examination includes noting down the vitals, the pulse and the blood pressure, the CVS examination, respiratory examination, abdominal, and examination of central nervous system. Now investigations. So investigations could be ocular, where we check for color vision, contrast sensitivity, visual fields either by static or kinetic, and then we have visual evoked responses whether flash or pattern. Color vision is an important test. In optic nerve disorders, we have red-green color blindness, while macular disorders, we have blue-yellow. And optic neuritis, we have red desaturation test, where we can show a bright red color with the either eye. And formal testing should be done with the help of Ishiaras or any other test. Contrast sensitivity should be done. It is a very sensitive test. It gets affected before the visual acuity, and it may not completely recover. And we have almost all electronic visual charts where we have these Pelly-Robson's kind of chart which is available. Now, systemic investigations are a battery of investigations. They have to be selected depending upon the profile and the symptoms of the patient so that they are best fit. So in the end, I would just say a methodical exam and a good workup is a must to arrive at good diagnosis. Thank you.